intercostal space. It's located at the between the third and the fourth intercostal space at the left chest, the left side of the chest. After that, we are going to listen to the mitral area. And we say that the mitral area is located at the apex area. Apex, so the place we will get our apex beat, that is where we are going to listen for mitral valve sound. And our apex area, we say the normal apex area is the fifth intercostal space at the mid-clavicular line. The left fifth intercostal space at the mid-clavicular line. So those are the steps to examine the cardiovascular system. So today we are going to be talking about the pulmonary system, the respiratory system examination. So respiratory system examination also follows the same sequence. So we're going to follow the same sequence, the IPP, IPPA pattern of examination. We are going to follow that pattern, IPPA. So before we put in now, I'm trying to share my slide. Let me put up my slide to share the slide. So just the same way, the same pattern we used to follow this examination yesterday. We are also going to use the same pattern today. So I'm going to guide you guys. Yes, it's called either it's either you call it pulmonary examination or you call it respiratory system examination. So pulmonary system examination or respiratory system examination. We can also call it chest. But chest examination is actually not the right term to use, because when we say chest, of course, there are other things in the chest. The lungs is not the only thing in the chest. We have the heart in the chest as well. So the better term to use is either the respiratory system examination or the pulmonary system examination. So that's what we're going to be dealing with today. So let me share my slide so that I will run through all the steps in examination of the respiratory system. Then we are now going to watch the video, just as we did yesterday. Watch the video. I'm also going to send the link of the video to the web page so that you guys can listen to it at your own free time. So all these things are very easy, and what we're actually dealing here is just the basic of all of these examination. We are not really doing anything advanced, just basic, what things you need to know so that you can be able to pick any pathology whenever you are attending to a patient. Okay. So let me check. Where do I have that slide? Respiratory system examination. Okay. Trying to share the slide. Respiratory system rehabilitation, basic medicine, respiratory system examination. I'm coming now. Just trying to share the slide. Okay, so while I try to check, I'm just trying to see where in my laptop I save this presentation right now. But while I try to locate the folder where I saved it, I want you guys to, if you can, please jot down some things. Please go ahead and jot down some things. If you can jot down some things. So the same approach that we used yesterday, the same grip, will apply to this presentation. So we are going to greet the patient. We are going to establish rapport. Greet, good afternoon, sir. Good afternoon, ma. So we are going to establish rapport. What does rapport constitute of? How are you doing today, sir? How are you doing today, ma? So you are going to show empathy to the patient. Always you show that you are caring for this patient. Always put smile, so that the patient can be more relaxed with you. So the patient can have more confidence to volunteer information to you, to allow you to touch him or attend to him or do all the things you want to do without having any issue. So that's why you need to establish rapport. Establish rapport by asking the patient, how are you doing today? How is your health? Hope you are getting better. The patient might just smile to you and tell you, I'm getting better, or it's still the same. So that way you have been able to establish rapport with this patient. So after establishing rapport in the grip, the next thing is to introduce yourself. You are going to introduce yourself. I am Mr. Paul. Just as usual, I am Mr. Paul. I am the person that will be attending to you today. So I am Mr. Paul. I'll be the one that will be attending to you today. So that is introduction. You are introducing yourself. So after introducing yourself, the next thing is to take permission. I want to examine you now. So, sir, I want to carry out the examination on you now. So that is permission. So after uh, seeking permission from this patient, you are going to put the patient in anatomic position. I hope you guys have learned what anatomic position is. Anatomic position is supine. Patient will need to be supine, with his or her hand laying by the side of the bed. So the patient is not going to bring his hand and cross it on his body, or cross his hand, put his hand on his neck. No. So the hands are not expected to touch, to be on his body, but just to be at the side of the bed. And the palms must be facing up. So the patient will lie supine, that is with face facing up, and the two hands are going to be by the side of the bed, and the palm is going to be facing up. So the palm will not face down. The palms of the patient will be facing up, looking upward. So a patient in that form is said to be in an anatomic position. So there's no flexion at elbow, there's no flexion at the knee joint. Everything must be extended with the palm facing up. So any patient in that position is said to be in anatomic position. So all the patients we are going to examine must be in anatomic position. So after putting the patient in anatomic position, the next thing we want to do for this patient is to expose the patient. But before we expose the patient, we must screen the patient. We must screen the patient. So if there are curtains around, you must make sure that those curtains, you use it to close. You use the curtain to close the curtain so that it will be only you and the patient in that particular room. I remember what we have talked about in terms of a chaperone. If if you are a female and you want to examine a man, you must call in a chaperone who is a man, a staff of the hospital, might be a fellow nurse, might be a physician assistant, or any other fellow health worker, to come and stay there while you start to examine this patient. So after you screen the patient, after you have screened the patient, then you now ask the patient to expose uh, expose him or herself. So for chest examination, again, if it's a female, you will also have to expose the patient or the chest and the abdomen to the level of the umbilical region. But then for a woman, you must make sure that the breast and the nipples are covered. So you get a bed cover and fold the bed cover and use it to cover only the nipple and the breast area for a female. But for a man, you don't need to cover that place. You don't need to cover that organ. Just bring down the clothes to the level of the umbilical region so they can be able to see both the chest and the abdominal wall very well. So after that, after the exposure, then we are going to apply the principle of IPPA: inspection, palpation, percussion, and auscultation. So respiratory system examination is one of those examinations that you must do the four. Remember, in general physical examination, we said we are only going to be doing inspection and palpation. There is no percussion in general physical examination, and there is no auscultation in general physical examination. In cardiovascular examination, we said we are going to be doing inspection, we are going to be doing palpation, we are going to be doing auscultation, but there is no percussion. But in respiratory system examination, we are going to be doing the four of them. So we do inspection, we do palpation, we will do percussion, and we do auscultation. And we're going to be doing those things in that sequence. So just from what we have learned before, inspection still follow the same pattern. We are going to inspect the head, we are going to inspect the chest, we are going to inspect the abdomen, we are going to inspect the leg. What are we looking for? The same thing, scarification on the face, the neck. Then when we come to the chest, we are also looking for both scarification. We are looking for any tribal mark. We are looking for any deformity, chest deformity as well. We are looking for we are also looking for chest movement and expansion just by looking, but we are going to demonstrate that much more better with palpation. So we are looking for chest movement and expansion just by looking if the chest is moving adequately the way we expect it to move or not. So at the abdomen, we're also looking at the abdomen, if the abdomen move with respiration or not, if the abdomen move with respiration or not. So we're also going to look for, just inspect the leg to see if there are also scarification marks, if there are also tribal mark on the leg, tattoo and other things. But also we're going to look for if there are swelling. We are just observing, we are just inspecting, we are not touching, we are not palpating. If we see swelling, it might also tell us give us some additional information. So I can't find this my slide. Okay, so please just write these things down. Later after the class, I'm going to find the presentation and I'm going to send it to you. Not the things, just be noting those things down. I'm going to find the presentation. I'm going to send it to you. I'm also going to we're going to play this video. Let me just give you a guide on what we do in respiratory system examination. So after we have inspected this patient, after inspection, the next thing we are going to do after inspection, the next thing we are going to do for the patient, the next thing we are going to do for the patient is to count the respiratory rate. We are going to count the respiratory rate. Here, in counting the respiratory rate, it is advisable to count the respiratory rate for 1 minute. Don't use the method we applied in cardiovascular examination, where we said we can count the respiratory rate only for maybe for 15 seconds and then multiply by 4, or count the pulse rate by for 15 seconds and multiply the value by 4, or count the pulse rate for 20 seconds and multiply by 3, or count the pulse rate for 30 seconds and multiply by 2. No, in respiratory rate is different. Respiratory rate, it is advisable to count the respiratory rate for 60 seconds, which is 1 minute, and you are going to report it 20 cycle per minute, or 15 cycle per minute, or 16 cycle per minute. Remember, we said in an adult, the normal respiratory rate falls between 12 cycle per minute to cycles per minute. From 12 cycles per minute to 18 cycles per minute. Hello?
Yes, sir. I did not see your slide, sir.
Yes, I said I'm going to send the slide. I'm trying to see where I saved it. I'm having difficulty trying to locate where I saved it in my system.
Okay,
and since of running out of time, I'm going to just try and jot some things down. After the class, I'm going to look for it. It has a lot of picture on it. That's why I actually wanted to present it, because I put a lot of picture on it. But it's taking much of our time, which we can't afford to delay anymore. Okay, let's see if it's this slide. So in that sequence, we said for an adult, the normal respiratory rate is between 12 to 18. But in somebody who is in the hospital, in a hospital bed and sick, we said respiratory rate can move up to 22. So we can have between 12 to 22. That's the normal respiratory rate for an adult. But if it is me and you that is up here, moving around, not sick, not on sick bed, what is expected from us, it should be between 12 to 18. But somebody who is sick in a hospital bed, it can actually move up to 22. So I'll find the slide now. So just give me 5 minutes so that I can let me share it so I can use it to the much more better. So before we quickly go into the video is also not much, just like about the same 12 minutes, just like that of. So after checking for respiratory rate, next thing we are going to check about is, after we are going to check for trachea centrality. We are going to watch the picture on trachea centrality, what it constitutes of. So after trachea centrality, we are going to check for chest expansion, if the chest is expanding as expected or not. After chest expansion, we are going to check for what we call tactile parameters. Don't be scared of a big name. It's not anything big name. Tactile comes from touching. Tactile, of touching of skin. So premises is just a sound that we hear. Okay, let me go to share. Let me see. System. Why is it showing me error? Okay, let me open it up and then show, and then see if I can share the slide by sharing my screen. Okay. System just so slow. Okay, so can somebody see my screen now? Hello, guys. Please, if you can see my screen, just indicate that you can see it. Hello. You can see my screen?
We can see.
Yes.
Okay. So what I've outlined there is the sequence of respiratory system examination. So the first thing we are going to do is the respiratory rate. The respiratory it just straightforward. What we do is we are going to count it. We are going to count it. And the method that is applied in counting the respiratory rate is that you are going to distract the patient. So how do you distract the patient? You are going to put your fingers on the radial pulse as if you are checking the pulse, because you don't want the patient to get nervous. You don't want the patient to get nervous that you want to check the respiratory rate, and the patient can get nervous, which can alter the respiratory rate you are going to get. So you just put your fingers on the radial artery as if you are counting the pulse rate. Meanwhile, you are just looking at the patient's chest and you are counting the movement. Inspiration, expiration, inspiration, expiration, inspiration, and expiration. Just checking out the chest movement, the chest and abdominal wall movement, not only the chest. So that's why you need to expose this patient to the level of the umbilical area, so that I can be able to check both the chest and the abdominal movement, chest and abdominal wall movement. So as your chest chest and abdominal wall are moving up and down, up and down, up and down. You are counting 1, 2, 3, and you count for 60 seconds. So it's not postulate that you are going to count for 30 seconds. So in respiratory rate, you must count for 60 seconds. So everything you get is, you get 20 cycles per minute. You get 15 cycles per minute. So you say the normal, we say that the normal respiratory rate for an adult is between 12 to 18. For somebody who is critically ill, on admission, up to 22 can be accepted. And here we have a table that shows us the respiratory rate for age-related respiratory rate. So in minutes, people that are 28 days or less than 28 days old, their respiratory rate can actually be up to 50. They can actually be up to 50 from the 50 to 60. But as the person now starts to get respiratory rate will start to decrease. It's a table about respiratory rate. So I'm going to count. I'm going to count it per minute completely. So after checking for respiratory rate, as I have described before, by palpating the radial artery, just to describe the patient, we are going to check for trachea centrality. So that's the next step. How do we check for trachea centrality? This is the picture of the pitch, how we check for trachea centrality. You can see that you are still using your right hand. So all the examination constitute of using the right hand. So you use the right hand, and you are using the fourth finger to press on the head of the left clavicle, the head of the left clavicle. And you are using your index finger to press on the head of the right clavicle, the patient's right clavicle. So you are now using your middle finger to trace the trachea, to make sure that the trachea is at the central. So you use the middle finger and move upward, all the way to where we are seeing the structure there, which you call the Adam's apple. You can see it pronounced in that place, the layman term, the Adam's apple. So you move all the way from down where you are seeing that structure. And from where you are seeing that structure, the Adam's apple, you move downward again, just trying to trace the centrality of the trachea. So when you trace it and there's no deviation, your middle finger is still straight, it means that the trachea is central. So there are so many things that can cause the trachea to not to be central, to deviate from central. If this patient has had maybe a puncture, somebody carry a kitchen knife and puncture the chest, and you see that all the air that's supposed in the lung, they now move out of the lung, because the lung is covered. The lung has a small pouch, but the whole lung itself is covered with a sac, a little nylon that covers the lung. So each lung is covered with a small nylon that forms so that nylon prevents oxygen and air from moving out. The nylon covers those oxygen and air, but when somebody punctures the lung, the air and oxygen can move out of that nylon, and they will now be free on the chest wall. So in doing that, you can actually push the trachea to the other side. So we call that pneumothorax. So pneumothorax is an example. Pneumothorax is an example. Massive pneumothorax is an example of one of the things that can cause the trachea to move to the opposite side. There are so many other causes. Maybe as we go on, we are going to see many other causes that can cause the trachea to move to the opposite side. So that's how we are going to check it. This is a patient that comes to you maybe in difficulty in breathing. You want to ascertain what is the problem of this patient? Is it pneumothorax, or is it community-acquired pneumonia consolidation, or what exactly is happening to this patient? So must check the tracheal centrality to know, at least to rule out that it is not pneumothorax, which I have explained, air escaping out from the lungs to be freely within the chest wall, that is causing this problem. So the first one is respiratory rate. The second one is tracheal centrality. After checking for tracheal centrality, the next one we're going to check for is the chest movement and expansion. I told you that chest movement and expansion, you are looking at it when you are inspecting, but still you are going to be palpating. You are going to be palpating the chest. How do you do it? Use your fingers and cross on the two chest, the bilateral chest wall, and you put it there. Try to approximate your hand to come close. As you approximate your hand to come close, you now tell the patient, sir, breathe in and breathe out. Breathe in and breathe out. Breathe in and breathe out. As you're moving, as the patient is breathing and breathing out, you are seeing how close the two thumbs are going to come close to each other. Breathe in and breathe out. Those two thumbs, the two thumbs that are seen there are expected to come very close to each other as the patient breathing, and as patient breathe out, they're expected to separate from each other at almost equal distance. At almost equal distance. So any of the thumb that is not actually hello. Hello? Hello?
Hello, sir.
Okay. You guys can hear me now, right? Okay.
Yeah. Yes, sir.
So there was internet issue the other time. That's why. Okay, can you see my screen now?
Yes, sir.
Yes, sir. That's it, sir.
Okay. Okay. This one is